Good afternoon, everyone. Thank you so much for having me here and attending during this COVID-19 Zoom virtual times. My name is Sebastian Tello-Trillo. I'm a professor of economics and public policy at the Batten School at UVA. And I'm an economist that mostly focuses on topics of health insurance, mental health, and more recently, I'm getting into HIV. Today, I will be speaking and hopefully answering a bunch of questions on the umbrella topic of health insurance and the time of COVID-19. I will probably be speaking for about 10 to 15 minutes, specifically on the US context, and then I'll just open things up for questions. Again, make sure that you submit your questions through the Q&A function that you have below, and I'll try to address them. I'm less familiar with other contexts that are not the United States, with the exception of Peru. So I can dig in a little bit more there, but this will be broadly a US conversation. And at the end of the day, too, the idea is just to get a broad knowledge of what the situation is, and maybe for you guys to solve any doubts that you may have or get some ideas. So without further ado, I think I'll start. I like to start at the beginning when it comes to health insurance. It's such a big a topic, and there are several things that we can touch on. So in the framework that I like to think for talking about health insurance and COVID, I think of it as like four kind of like big topics and items. One is the issue of coverage. This is the questions of who is being covered and how they're being covered, what is being covered, like what kind of treatments, the network of the insurance, and so on. How is it being covered? What is the structure of co-pays, premiums, and subsidies? That's kind of like all those questions are under the coverage. There is a whole kind of like different section when it comes to payments and reimbursement. This is just the idea of how much is insurance paying doctors and hospitals? Like how much are we paying in for each services, and how that varies across insurance. All of those topics come from that under the umbrella of payment and reimbursement. Then we have the issues on funding, which is basically how do we pay for health insurance from the government perspective, for Medicaid, for Medicare, or for private health insurance in terms of premiums and subsidies. What is the process, and to who this funding kind of like relies on? And then finally, I think the last topic is like impact of health insurance. These are answering the questions of, does health insurance work? Does it help mitigate financial shocks? Does it have an impact on your health, on your physical health, on your mental health, on other parts of your life? And so there's a lot of questions of impact of having health insurance that are important to understand. For the purposes of this talk, of what we're talking about today, I'm mostly gonna really talk on the coverage part, but I'm happy answering questions in any of these kind of like four bins of topics. Okay, so when it comes to coverage, the main way that COVID-19 is and probably will be affecting coverage is through the increases in the unemployment rate. We have an unemployment rate that it's currently hitting about 15% and going up. This could be also biased downward, so this is kind of like a baseline estimate of the unemployment rate. If you work better with numbers, this means that about 30 million people filed for unemployment between the weeks of March 15 and April 25th. So i.e., there's a lot of people losing their jobs. I think there's some estimates from the Federal Reserve Bank of St. Louis that unemployment rates may hit or could reach as high as 30%. So clearly, this is something that is affecting a lot of people, and this is kind of like the main way COVID will affect coverage. And the reason why that's the case is because a lot of these people that are losing their jobs are losing the health insurance that they have through their jobs. About 60% of the non-elderly US population has some sort of employer-sponsored insurance. 60%, so that's a lot. And if you like numbers, that's about 160 million people under the age of 65 that have some sort of employer-sponsored insurance. And so when you're talking about an employment rate increasing from 15 to, let's say, 30%, you're talking about a lot of people losing their jobs, and therefore a lot of people losing coverage. And that's kind of like the main kind of like mechanisms in which COVID-19 is affecting health insurance rates or will affect health insurance rates. So we get this idea, I lost my job and therefore I lost my health insurance. What can I do, right? As a simple, practical individual, what can we do? Well, here's this nice flow chart that this journalist that works for the American Prospect, I believe his name is John Walker, put together that in some sense summarizes your options. So what I'm going to speak to is just a summary version of this flow chart that hopefully I'll try to make it a little bit more bearable. Okay, so what are your options if you lose your job and therefore you lose your insurance? Your first option is going to be to get into your spouse's health insurance, obviously provided that you have a spouse and provided that your spouse has a job that has health insurance. So that's kind of option number one. Option number two is if you're under 26 and you're dependent, or you can be claimed as a dependent, then you may have the opportunity to have dependent coverage. Usually, I don't think this is a big category for the COVID-19 context, mainly because a lot of these people already were probably enrolled in their parents' health insurance plans. So that may not be an issue. But if your parent is losing that job, then that could be an issue for you. A third thing you can do is just you can go and buy insurance, right? You can go into the health insurance marketplace, and because you just recently lost your job, you can potentially qualify for some subsidies. So that could be helpful. I think a note that is important here is that usually the health insurance marketplace has some timings on when you can enroll. Depending, the federal government hasn't done anything special on that. Depending on each state, they have opened a special enrollment. But overall, across the country, if you lose your job, then you get the opportunity to enroll in health insurance market. So just by the mere fact of losing your job, you kind of have access to this. A fourth option is Medicaid, right? Your income has lowered now, right? Because you got kicked out of your job. Maybe you're eligible for Medicaid, depending on the states that you are. So this is where things matter a lot if your state did or did not expand Medicaid. Option number 5 is to apply for COBRA. So this may be the least popular or well-known amongst kind of like the broad population of an option. COBRA is a program that allows people to remain in their employer-sponsored health insurance plan as long as they pay their premiums. So this was kind of constructed for the type of people that I'm transitioning from one job to the other or becoming employed, but maybe I'm looking to be employed later. For whatever reason, you can get COBRA. You may think this is not that great. I'm like, okay, sure, I get to keep my same employer-sponsored insurance, but I have to pay for it. That kind of sucks. In this situation, it could be potentially cheaper than going and buying insurance on the health insurance marketplace. So that's something to consider. But the other part that could be important, or that maybe it's important for some people, is that if you already have paid your deductible, and just to recap, deductible is the amount of money that you have to pay before your insurance kicks in. That obviously ranges between $500, $1,000 to like $17,000. So if you already met your deductible, then you're better off staying in that plan, because any extra healthcare that you get, the insurance will kick in. Versus if you buy yourself a new plan, you have to meet the deductible again. So that could be a situation where you may want to get into COBRA. So that's another option. And then finally, there's free healthcare clinics, right? If this is you remaining an insurer and choosing not to get insurance, or maybe because you cannot get insurance for any of these methods, you can start going to some free healthcare clinics. We have here one at UVA that is a lot of the UVA School of Medicine community participates on it. And so that's an option. Obviously, it's a limited option. They don't have all the services. Okay, so it seems like there's a lot of options. What's the big worry? That we could, think about when it comes to people losing health insurance. So the big worry is that these options may or may not be available for everyone, and depends on where you live. So the overall final estimate, let's say, of the uninsured rate is going to depend on A, the economic condition of your state or your county, B, if your state has expanded Medicaid or not, C, where in the income distribution people are losing employer-sponsored insurance. Are these the high-income individuals that probably will be able to afford, a health insurance plan in the health insurance marketplace, or are these lower-income individuals? And accessibility and easiness for the healthcare marketplace. This is basically the idea of like how easy or not easy is to get health insurance through a marketplace. So all of these things are going to matter in terms of calculating a number of how many of these people that are losing their job and their insurance are going to remain uninsured. Fortunately, we have people who study this thing and they're starting to basically do some math to calculate some estimates of this. Remember that I talked about those 160 million people with employer-sponsored insurance. So in a base case scenario with a 20% unemployment rate, we think that about 25 million people of those 160 millions would lose employer-sponsored insurance. And in a worst case scenario, this is about 43 million people. So it's a substantial amount of people losing health insurance or losing employer-sponsored insurance. And so these are the people that are going to funnel into all kind of like the other options that they have. And again, we can do a math, and we can do this math based on previous recessions and how the unemployment rate changes and some other adjustments. This is taken from the Robert Wood Johnson Foundation or report. Obviously, these numbers could change. There's a confidence interval in all of these estimates. But the broad idea here is that if you're in a state that has expanded Medicaid, then out of those 25 million people, about 50% of them are going to go into Medicaid. About 23 or 24% of them are going to get insurance through the marketplace, and then 23% are going to remain uninsured. If you're in a state that has not expanded Medicaid, the part that is the health insurance marketplace, right, that orange bar, is going to remain fairly similar, right? The same amount of people. What's going to shift is how many people go to Medicaid versus remain uninsured. And so if you notice from these bars, really that there's a 20% of people that would be otherwise in Medicaid, but they're not uninsured because your state has not expanded Medicaid. So that's going to be a big difference between states that have not expanded Medicaid in terms of the uninsurance rates. But again, I always like to give some numbers because it's just percentages. Sometimes that's easier to work with people when it gives you numbers. So in that base case of 25 million people are losing employer-sponsored insurance, it's about 7 million or about a third of them will remain uninsured. That's kind of like what that estimate is saying in that base case. Then about 47% will be on Medicaid and 25% on the marketplace. Then, in a worse quote unquote case scenario, we have the same percentages, but we're going to have just more people remaining uninsured, which is about 12 million. And then we can do the same math, and we have about 21 million in Medicaid and 10 million in marketplace. The shares are going to be the same because it's kind of like the same model. It's just adjusting if it's a good or bad scenario. So what's the big takeaway here? It's like, okay, COVID is affecting insurance rate mainly through people losing their jobs. And this is going to, if things are the way they are and there's no big changes in sight, this is going to mean that we're going to see an increase in the number of uninsured people between 7 and 12 million more individuals that are uninsured. And for Virginia, this is about 160 to 200,000 people that will remain uninsured. Virginia is one of the states that has expanded Medicaid, so we're a little bit mitigated by that, but still is a huge number of people remaining uninsured. Just to conceptualize how big this 7 to 12 million number is, before, how many people were uninsured is about 27 million. So this is a 25 to 43% increase in the uninsurance rate. That's a lot. That's very high increase in the number of people who are uninsured. What is the second takeaway? The Medicaid is doing a really good buffer job, or potentially it's going to do a really good buffer job. And this is something that is actually not surprising. This is something that we've learned from previous recessions and previous pandemics too, that we study historically, about the really good job of Medicaid during a recession or a pandemic of basically capturing a bunch of people that would lose health insurance and providing them with that coverage. And so now we're kind of like reaffirming that, and we're seeing that again in the way that it's been able to work. I think this is also important to highlight that this is where ideas of block grants or capitated payments, it just means like the states gets $100 to spend in Medicaid. Those are now a little bit harder because in a situation like now, where we need a little bit more money to fund those programs, the states would be much more limited if they had that. So where do we go from here? There's a lot of different topics based on this context. So what I wanted to do with that is just give you the basic takeaway and basic context of what's happening with COVID-19. But we can ask a bunch of questions about Medicaid funding or COVID-19. Is COVID-19 covered under Medicaid and their insurance? Are people getting their regular medical care? What is the federal government doing? There's a bunch of things that we can ask and learn about this context. But this is where I would like to open for Q&A to see what kind of questions are you guys interested in learning a little bit more about this topic of health insurance and COVID. So I'll give you guys a second to write your questions under the Q&A, and I'll be happy to answer them. Okay, I think there is one question here. Sorry, I'm trying to find the question. Okay, here it is. How does this affect Medicaid funding? Yeah, so this is a really important and interesting question. So this is a hard time for Medicaid, because as more people are becoming eligible for Medicaid because they're losing their jobs, then what's happening with the state budgets is that the state budgets are also getting hit by a recession, right? Their revenues are plummeting. They're getting less taxes and less revenue. And so this puts a lot of pressure into states to create Medicaid cuts or take some decisions. There's very few things in general that states can do. They can raise taxes, i.e. raise revenue to help Medicaid. They can make program cuts. That means either kicking people out from coverage from Medicaid or offering less benefits, or pay less to providers, right? Which is specifically like awful during the crisis where they're already not getting enough money. All of these options are not great in a crisis. They're not gonna increase their taxes during a recession. It's really hard to keep people out of Medicaid during a recession and so on. So the states are really constricted. What has been done right now is that under the Families Act, they've increased. So Medicaid is funded by the states and by the federal government. The federal government has now said, hey, we're going to increase our share of the funding by 6.6 percentage points, which is great in the sense that they're helping out, but it's not so great in the sense that in previous recessions, they've done that. Plus, if for every increase in the unemployment rate, we're going to increase our share more. So basically, they were trying to just say, okay, if your state is getting hit more and more, we're going to take a little bit of the bill. The federal government is going to take a little bit more of the bill. That's so far not occurring right now, and obviously, there's been a lot of ask from the states to the federal government to be like, we're going to really need a lot of help with money for Medicaid because a lot of people are coming in and we cannot afford them. Okay, so I think I answered this question. A couple more. Let's see. Is there any data? This is from Brian Sulaga. Is there any data on who are the individuals that would lose employer-sponsored insurance? What kind of employers or income brackets are in these employees? Yeah, this is a great question. So let me show you. I think I have a slide here on a little bit of the context. Let me see if I can. Oh, maybe don't have it with me, but if we cut by income, most of the people that have employer-sponsored insurance are a little bit on the higher end of the distribution rather than the lower end of the distribution. Why? Because these people who have lower income maybe have part-time jobs or the jobs that offer the same kind of benefits. So in that sense, that's kind of like how things looked before people started losing their employer insurance or getting kicked out of the jobs. What we currently are not super secure or sure about is like, well, is this recession really affecting these people because they're losing these types of jobs or this people? And so I think right now it's a mix. We don't know who currently those are. From past recessions, we learned that are kind of across the spectrum. But I don't have any potential like really good numbers for you right now on that. So that's something that we can speculate on, but based on past recessions, But it's really a question of if there are more about the small businesses, then that could be part of the lower income that is getting affected more. Okay, great. So that's that question. Let's see, a question from Bradley. When individuals lose health insurance, what is their primary result? Do they forgo essential or not essential medical care, continue to seek medical care and incur debt? Also, what is the result of losing health insurance and mental health? Okay, this is a great question from Bradley. And if I almost want to say it's a planted question, but a lot of my research that I worked in the past few years is about people losing health insurance, especially people losing Medicaid. From what we know in this literature, and what we found is that they don't do so hot. So it turns out that Medicaid and health insurance actually really do a really good job in mitigating financial shocks. So when people are becoming insured and they have a medical event that could happen to them, which is now more likely because of COVID, they get this hospital bill and they really can't pay it. What do? They stop paying their mortgage, they stop paying maybe their car loans, they start to accrue debt on their credit card. A lot of people put their debt in their credit card. And then you start becoming severely delinquent in your debt. It pushes some people to bankruptcy. So financially, it's just a disaster for some of these people. Some people can weather the effects better depending on your networks and if you have a lot of savings. But there is a lot of people to which it affects them a lot. When it comes to do they forgo essential and not essential medical care? Yeah, so I think they forgo both of them. Currently, right now, with the COVID context, we see that a lot of people are not just consuming their regular care or their that they would otherwise get, like the surgeries and things that were more like elective procedures. I think there's a stat there that about in some hospitals, they've seen a loss of revenue of 40%. That just means like people are not doing the stuff that they were doing before, obviously for obvious reasons. So then the hospitals are getting less money and maybe they're not getting paid much for COVID because people aren't insured. So this is spiraling into the hospitals as well. So yeah, I think in this context, we're going to see both. We're going to see therefore go essential and non-essential work. And in terms of what is the role of losing health insurance and mental health? So this is interesting. Because in the research that I found is that we don't see a lot of traction yet on losing health insurance and mental health. And this came a little bit to a surprise to me. Initially, we had this findings of like worsening in mental health care, but with the indicators that at least I researched, there wasn't too much of a change. I think the explanation for that is that the indicators that I was using in my own research were things like inpatient stays in hospitals that are a little bit more extreme. The problem with studying mental health in the population level is that the metrics are a little bit hard, right? Because if we're going to trust a metric of how are you feeling, that could be a little bit more wonky and noisy, and it's harder to study. So I think the jury's still out, but it's not as cut clear as I would like it to be, or as imagine it would be relative to physical health. We do know things from the Oregon health insurance experience that people were reporting just better health, physical health, by the fact that they have health insurance, even though their tests did not made it more positive. So that could be an indication that they just feel less stressed and therefore it's improvements in mental health. Okay, I have other questions here. With COVID-19 expanding existing disparities in healthcare outcomes, do you think there's an opportunity for public policy to restructure healthcare insurance in terms of access quality, or do you think these disparities are widening at a rate that is too expensive to mitigate? I think both are true. Victor Fuchs, which is a somewhat famous health economist, says that every time there is a huge shock to society, we start reevaluating how we do healthcare. That happened, in the wars and Medicaid and Vietnam Wars and all this other stuff. And so, there's an idea that this pandemic can push into help us think about, a different healthcare structure. I think I showed you guys that flowchart where it seems really complicated. And if I show you the flowchart from another country, it's just, you go to the doctor, you still get healthcare and it's fine. So I think it will push us. It will start that conversation a little bit more. When it comes to disparities, I think this is going to widen the disparities. Absolutely. I think we're seeing that with the data. We'll be able to do something in the meantime. I think right now, I think the responses in order to mitigate the effects of COVID are kind of the same everywhere, which is socially distance, make sure we're testing, then getting ventilators out and so on. It's a little bit harder to target those things by the disparities that we think, as long as they're, with the exception of like the very visual ones, like rural disparities. Okay, we know we can put more resources in rural areas. When it comes to racial disparities, which are, I think, the most salient right now, we can target neighborhoods, or certain type of hospitals that serve differentially, but it's just a little bit harder to do from the mechanical government point of view and the state point of view. But that's a good question. So I think the answer is yes. Good question for David Bradford. Do you have any feel of how much pressure the potential loss of access to EBHH on political pressure to either strengthen the subsidies for individual purchases or ACA exchanges or build support for Medicare for all? Yeah, so this is kind of like a similar question. So again, I think from what we've seen before is that every time there is major changes, we do see a lot more pressure putting in to create some changes. At least from the stuff that I'm reading, there's a big push on the Medicaid side to making Medicaid expansions a lot easier for states that have not expanded yet. So that's number one. Number two, to get more money onto Medicaid, so they can pay a lot. Number three is just to push on the easiness of the health insurance marketplace. That is just to hire more staffers or whatever needs to be done to make it super easy and understandable for people to get health insurance through the marketplace, and push people for the exchanges. And I think that's, to be honest, that to me seems like in the interest of the federal government to do, just because the more, even if we're doing more subsidies to a lot more individuals in the marketplace, at the end, those people are going to have a private health insurance. And if anything happens to them, that private company, that insurance is in theory going to pay, or hopefully should pay, for all those treatments, right? As opposed to if I put people in Medicaid, then it's kind of like the federal and state government putting them. So I see an incentive from the governments to push to make this accessible of the ACA exchanges. So I do think this is going to create political pressure on all of those aspects, on the Medicare for all kind of type of style reforms, or on the reform of like, let's just make it easier for people to get health insurance because it should be easier. Rachel asked a question: how are states with work requirements for Medicare responding to the unemployment surge? Yes, so this is an interesting question. So I don't know how they're currently responding. I'm blanking out on, I think there's only a couple of them that actually do have it in place right now, Medicare work requirements. I think there's a lot that wanted to, but I think it was struck down in the courts. But long story short, from what we know from the Arkansas and different state cases, is that there are embedded in the law some exceptions onto these rules of like, if you're still looking for the job, you can still get Medicaid. But at the end of the day, border requirements or anything that makes it a little bit more difficult for people to get Medicaid are the things really not to do. So my guess is that those states are not doing so well in the sense that less people are coming into Medicaid. And so they're remaining uninsured, or they're being forced to go to the exchange market, probably forced to be uninsured. And so that's not going to look great into the own state's budget, because at the end, if those people end up in the hospital, that's going to be either a hospital bill that the hospital can afford, or it's just bad for that same individual, right? And so then we are leading individuals to bankruptcy, which is not great. Let's see, as individuals lose, will utilization of emergency medical service increase due to lack of access to preventative care? If so, how could local governments cope with an increase in unpaid ambulances fees given their current budget constraints? Okay, so this is a two-part question. So first, will utilization of kind of like going to the ER will increase because people are not going to the doctor? Yeah, so this is definitely a concern that a lot of the medical community has. We do have some evidence that as you go more to your primary care doctor, that's going to decrease potential new ER visits. It's a little bit smaller than I think what people think. It's about like, I think 0.25 effect, but anyways, that's getting inch numbers. So I think we will see this, and I think we are seeing this. I'm seeing this at least in a couple of stories here and there, but those are stories. They're not a concise data story at least. But it's definitely expected for a lot of people that are not getting their basic medical care, that we're going to see a lot of that influx in the future. So if so, how could local governments cope with an increase in unpaid ambulance fees given their budget constraints? I think this is a good question, but this is a question for all the other stuff that is happening. How local governments can deal with a lot of increases in expenditures that they're not seeing given their current budget strains. I think this is where, in some sense, if we think of the federal government or the state government kind of like as the insurers, as this last resort kind of entity that helps fund these situations, then the answer is like, well, this is in theory where we ask the local to the state and the state to the federal government to help them with the funding of these things. And this is where a lot of the people are pushing for more benefits and more funding for the different programs. If those don't come in, then they're going to have to rely on either increasing taxes in the future, paying less to those providers in other areas, or finally, I don't know, getting money from private entities or something like that. So not a lot of options there. The CARES Act and other federal legislation. Sorry, let me see if I am. So we're heading to the last question. Yeah, okay. Let me answer this last question, if I can be briefly. The CARES Act and other federal legislation has a portion of money to healthcare providers and hospitals, but not target interventions towards individuals who may lose health insurance. With this rationale behind this, is it primarily to compensate hospitals to care for insured individuals? Yeah, okay, so the question is that the CARES Act has put in some money that goes to healthcare providers. So kind of like, what is the rationale behind this? The rationale is exactly what you guys would think, which is the hospital revenue, the way hospitals work in a very, very simple thing is like, okay, I'm going to get some people who are insured. I'm getting people who have private insurance, people who can pay. I'm going to use that money and I cross-subsidize across my patients, and I'm trying to make a profit out of that. So right now, the revenue is decreasing because a lot of those people are not getting that same care as usual. And so what's going to happen there is that they're kind of like constraining in the cash that they have. And so part of this money is to like, here's some cash so you can pay your employees so you can keep functioning in because you just need cash. So in that sense, that's kind of like the rationale, because there's a lot of people who are coming in, they're not paying, number one, but also because they're just getting a lot less revenue. Okay, great. There were a lot more questions that I couldn't get to, but thank you so much for coming. I hope this was informative. Happy to answer a lot more questions offline. Just shoot me an email at sebastian.tello@virginia.edu, or you can find me on Twitter too. Anyways, thank you so much. Goodbye.